Hello everyone, and welcome to today's webinar, The Impact of Staff Safety on Patient Safety. Your presenter today is Dr. Michael Sinnott, Senior Clinician and Innovator with ClickSmart. Michael is a Senior Clinician and Innovator with strong management, research and education skills. Michael was involved in clinical medicine for over 35 years before retiring in 2018. The majority of that time was spent in the emergency department. In the field of research, Michael promotes an evidence-based approach to emergency medicine, research and practice, and the development of a culture which generates and supports research findings. Michael was a driving force in designing the Queensland Emergency Medicine Research Foundation. Michael has contributed to over 40 publications and is a world leader in research regarding staff safety in healthcare. His expertise led him to become involved in the development of safety guidelines and legislation in the United States and safety standards here in Australia. In the commercial space, Michael is the co-founder of ClickSmart Proprietary Limited and SmartStream Proprietary Limited, who innovate and commercialise safety medical devices. Thank you so much for joining us today, Michael, and welcome to the microphone.
I would like to start by thanking Sue Walker and her team at NCPDI for their introduction and invitation to present this CPD session. I believe staff safety is important for you, your patients and your colleagues. Further, I believe that working in a safer environment will replenish the enjoyment and pride you get in doing your job well. The learning objectives for today's session are, firstly, to learn the history behind staff and patient safety attitudes. We will refer to both the scientific and grey literature to achieve this. Secondly, to understand how staff and patient safety is linked and why staff safety has been traditionally ignored. Your safety and mine should be important enough in its own right to prompt immediate cultural change. This isn't happening. So we will examine the linkage between staff safety and patient safety, and this should reduce the current resistance we have to overcome in promoting improvements to staff safety. The third objective is to review occupational safety hazards in healthcare and evidence-based methods for reducing them. We will drill down into some of the occupational hazards you as clinical staff face at work. Last but not least, we will explore how clinical practice can be made safer for both staff and patients. We will look at how you, as a humble clinician and/or educator, can make the clinical setting safer through participation at the national, organisational and individual levels. To achieve these learning objectives, we will review the theory and look at some case studies. We will focus on both historical and more recent events. Let's begin with a thought experiment. Please indicate which of the two people in this slide is the patient. I assume that everyone is pointing at the person lying on the hospital bed. This exercise is designed to establish our preconceived or subconscious assumptions and beliefs. For example, historically, the answer to this question has been intrinsically associated with that person lying down. Further, the patient is also viewed as the most important, if not the only, person in the room. We will revisit this at the end of the presentation to see if anyone's thinking might have changed. One of my favourite quotes is that the only thing new in the world today is the history you haven't read. So let's look at what has already occurred. The 1999 To Err is Human report was a global wake-up call. The Institute of Medicine's report, titled To Err is Human, Building a Safer Health System, included findings that there were up to 100,000 preventable deaths in American hospitals every year. I remember reading these stories in the newspapers and seeing them on TV. Like many of my colleagues, I threw my hands in the air in disbelief. Surely this was not possible. Those patients must have been terminal already. My next excuse was that the 44,000 to nearly 100,000 preventable deaths were occurring in the USA. Okay, but we practice much better medicine in Australia. However, over a short period of time, not only did I start to believe the core message, that is, that hospitals can be very dangerous places for patients, I started to see this danger and avoidable harm in my own hospital and my own clinical practice. Only recently, I learned about the early Australian experience with patient safety issues in hospitals. 26 years ago, the Minister for Health spoke to Parliament about a recent report into hospital safety. The report found that nationwide, in a year, 230,000 hospital admissions were involved in a preventable adverse event. So after we got through the denial phase, how did we react? Let's start by looking at the factors that were postulated to be behind these dreadful patient safety statistics. James Reason, a British psychologist, very quickly stated the obvious. Doctors and nurses don't go to work to deliberately hurt or kill patients. So something else must be happening. He explained what was going on as a series of systems errors. He used the Swiss cheese model to explain this. Shining a laser pointer through one hole in one piece of Swiss cheese standing vertically is easy. To line up two holes in two different pieces of Swiss cheese is more difficult. The degree of difficulty increases exponentially when more pieces of Swiss cheese are lined up, as in the illustration above. The laser pointer indicates the sequence of events in patient care. The holes represent a systems error that could lead to a poor patient outcome. On its own, the hole is not much of a problem. But when a series of the holes line up, bad things happen to patients. I'm sure most of you have heard at least one case used to explain this model. Please let me paraphrase a bit in the interest of time and simplification. An 18-year-old young man was in hospital in the UK. He had lymphoblastic leukemia with cerebral metastases. The metastases were causing agonising headaches. This young man had an IV cannula in his forearm for chemotherapy and a cannula into his CSF for more powerful pain relief. Sunday morning at 8 a.m, the new intern came up to the patient and said hello. He introduced himself and explained what he was going to do. But by accident, he injected the chemotherapy into the wrong cannula. It went into the CSF, the patient fitted and later died. Why did this happen? The charge nurse was acting up as the aide-on. The ward pharmacist was on holidays and her replacement had little or no experience with chemotherapy. The doctor was an intern. And like most of us would admit in hindsight, we didn't have much idea about what was going on back then. And it was Sunday, so there was less staff around. If any one of these four issues had not occurred, the mistake would have been picked up and prevented, and the patient would not have died from a preventable cause. Systems errors were identified as a key cause of preventable error. James Reason postulated that at least 4 or 5 systems failures had to occur at the same time before a patient would come to be harmed. As a result, much attention was focused on identifying individual systems errors and addressing them before they caused harm. This included one overarching principle of no blame culture. This is essential to bringing to light the identified holes. Coming back to the ERI's human report, they recommended the following to achieve their 2 proposed changes, namely a no blame culture to facilitate a focus on patient safety. Let's look at some practical application of the recommendations. They stated a need to establish a national patient safety centre to enhance the knowledge base about safety. Tick. The Australian Commission on Safety and Quality in Healthcare was established in 2006. They were then tasked to develop the National Safety and Quality in Health Services Standards, which now number 8 and make the basis for hospital accreditation. Secondly, implementing periodic re-examination and relicensing was recommended. Tick. Watching this webinar is part of your continued professional development. They identified the need to pay special attention to the safe use of drugs and to use proven medication safety practices. This still needs work. For example, electronic prescriptions have as many errors as handwritten ones, just different ones. They recommended the design of new reporting systems, mandatory and public for severe injuries and deaths, and voluntary and protected for minor injuries and incidents. Again, this still needs work. There is still a propensity for safety improvements to be only discussed on an ad hoc basis. They also restated the obvious, that safety be declared a serious aim, with the use of interdisciplinary team training and the use of simulators whenever possible. Again, still needs work. An enormous amount of resources, both money and personnel, supported by ongoing research, was injected into these recommendations, all aimed at improving patient safety and stopping at least some of these preventable deaths. Unfortunately, all that money and other resources have not achieved the improvements we were expecting, let alone wanting. Several studies over the past 20 years have shown that preventable adverse events are still occurring in hospitals, and implementation of preventative measures are patchy at best. So what happened? Did we miss something? The relationship between staff safety and patient safety was poorly understood. I believe it was wrong. In 1999, the authors of the To Err is Human report noted the importance of staff safety, albeit only briefly in one paragraph on page 24. But they stated that staff safety would improve as a consequence of improving patient safety. Time has shown this not to be the case. They were not the only ones to misunderstand the importance of staff safety. Of the 8 Australian National Safety and Quality in Healthcare Standards, not one is dedicated to staff safety. While we're on this slide, let me jump ahead a little bit. My belief is that had the authors of the 1999 report concluded that staff safety and patient safety were equally important, then the processes that they recommended for patient safety could have been duplicated to improve staff safety. The cost to run 2 essentially equivalent processes in parallel would have been less than double the cost to run just the patient safety process. The cost savings would have included process development, education, training, and cultural awareness, etc. Had both staff safety processes and patient safety processes been run in parallel, the return on investment would have been higher. As we will see later, the patient safety outcomes would have been much more successful, as safety would have been a congruent culture for all. Let's start this section with a historical comparison. Patient safety. The 1999 report, 100,000 preventable deaths. This statistic created headlines that contributed to the start of the patient safety movement. The history of staff safety in healthcare. An article published in 2000 showed 1 million shafts injuries per year and up to 70% unreported. No headline news, no staff safety movement. The two reactions are far from equal. The Public Citizen is an independent, not-for-profit consumer advocacy group that was formed in America in 1971. It is external to healthcare. In 2013, they published a report that once again stunned our professions when it stated that healthcare was a high-hazard workplace. The report compared our safety record in healthcare with other industries. Who would have thought that we suffer around 7 times as many musculoskeletal injuries as they do on a construction site? And who would have thought that we suffer around 7 times more assaults than they do in construction. Stop and think again. Yes, those figures are probably correct. I think our failure to recognise this is explained as a normalisation of deviance. If you work in the emergency department, you expect to be abused by the drug patients. If you nurse obese patients on the ward, you expect to hurt your back when one of them falls and you try to save them. For how long are we going to accept this normalisation of deviance? My research colleagues and I, from our position of being well and truly entrenched in the thick of clinical activity in our emergency department, have observed and published 3 key reasons why a clinician may ignore his or her own safety. Firstly, denial. We all know that the risk of contracting HIV from an infected patient is 1 in 300, and for hepatitis C, it is 1 in 30. But we all somehow know that the infection will happen to someone else and not me personally. In the early 1990s, I was a medical registrar working in Wattle Brae, the infectious diseases ward in which we treated all of our HIV patients. One of our nurses refused to wear gloves because she did not want her patients to think they were being treated differently. The inevitable happened. She had a needle stick. I remember seeing her go as pale as a ghost. In fact, she had to take 3 days sick leave due to the stress. Fortunately, she did not become infected. Secondly, self-sacrifice. I think that if you or I take a risk with our own safety for the benefit of our patients, we somehow feel like an even better person. In this cartoon, we see a child crying, not sick, and definitely not dying. The man on the left rushes across hot coals in bare feet, almost certainly injuring himself badly. The lady on the right is smarter. She knows that the child is only crying, so she puts on her shoes before she walks across the coals to console the child. Both are safe. Finally, and most worryingly, is that when we are injured, we all too often blame ourselves. This in part explains why 70% of all sharps injuries go unreported, and it also means that after an injury, we don't look at ways to prevent it recurring. A couple of years ago, I looked after 2 of our registrars who suffered sharps injuries only a few weeks apart. The first one looked a bit embarrassed and said to me, "It was my fault, I wasn't concentrating," meaning that he believed that he would never have another injury because he would never lose concentration again. This is an impossibility, especially in a hectic ED. The other registrar told me that it was her fault because she was rushed. Have you ever experienced these thoughts? I have been guilty of each one on several occasions. Now ask yourselves, if the staff don't speak up about their own safety concerns, how can you expect that management will know what is happening? And why would they do anything about a problem they are unaware of? So why is it that the healthcare industry, which is made up of highly educated and caring professionals, still lags behind most other injuries when it comes to dealing with the safety of our own staff? The ignorance occurs at all levels in the hospital, from management to the clinicians themselves. This 2009 publication outlines the institutional reasons why staff safety has been ignored in healthcare. They note that there is limited, sustained leadership commitment and allocation of adequate health and safety resources. At one stage, my younger brother worked for one of the big mining companies. He told me that at the start of all meetings, including the executive meeting, each person attending had to relate a story about a potential safety incident that they had experienced outside work, for example, at home. This was called a safety share. The theory being that if people took safety at home seriously, they would be more likely to be safe at work. Have you ever been to a hospital meeting that started with you or anyone else talking about a personal safety experience? Health and safety resources are not aligned with the corporate planning and budget cycle. Healthcare has well-entrenched, hierarchical and tradition-bound professional and organisational culture. Despite this, we believe the sum of our actions in relation to our own safety in the workplace will add up to overcome these barriers. They also note that there is an absence of comprehensive corporate analysis to identify, monitor, mitigate, and manage health and safety risks. We have created some tools to assist in this area, and they will be the focus of a future CPD talk. The healthcare workplace is made up of complex groups of professionals who have had different training and who are used to working independently and in silos. So what we can see now is that in addition to the human factors, there are organisational and government gaps that contribute to a lack of attention on staff safety. What can we learn from other industries? Dr. Jim Bajan was both a medical doctor and an astronaut. Many years ago, he gave a talk in Brisbane about his time at NASA when he was working with the space shuttle programs. He told us how proud NASA was of their strict policies that prevented mistakes. In short, NASA had a long-established 3 strikes and you're out policy. When you made your first mistake, you got a day off. When you made your second mistake, you were suspended for 2 weeks. And when you made your third mistake, you were fired on the spot. So this meant that when the aircraft engineer who was tightening a bolt on the outside of the space shuttle made a mistake and turned the bolt 13 times instead of 12 times, he was faced with a dilemma. Did he tell his boss about his mistake and become one step closer to being sacked? Or did he shut up about it and hope for the best? Hope that the extra turn had not threaded the bolt. After the fatal Challenger crash, things changed. NASA instigated a no-blame culture. So the aircraft engineer was encouraged to own up when he made a mistake. This meant his boss was firstly able to check that the bolt had not been threaded. And then the engineer, his boss, and other staff would try and work out how to prevent this mistake happening in the future. They came up with a pre-tension spanner to ensure every bolt was screwed in exactly the right number of times, eliminating the risk of human error. So NASA introduced a no-blame culture to improve safety, and this idea was also adopted, albeit later, by healthcare. If I could recap, there are still preventable deaths and injuries occurring in hospitals, especially when there isn't a systems-wide approach to preventing them. Similarly, hospitals lack a systems-wide approach to looking after staff safety. Staff and patient safety are intrinsically linked. Let's see how. I need to share how I serendipitously first noticed the link between staff safety and patient safety. Not surprisingly, it happened when I was working outside the clinical area, looking back in, a third-person perspective. About 10 years ago, I was demonstrating 2 new safety inventions to groups of nurses in Australia, America, and several countries in Asia. The first safety device was a new sterile version of the single-handed scalpel blade remover invented by my friend and colleague, Dr. Neville Henry, at the request of one of our ED nurses. The second was a safety device invented by a nurse from Rockhampton to open glass ampules safely. When I demonstrated the 2 products, I was surprised by the response I was met with. The nurses were polite and said the sterile scalpel blade remover was very nice and simple to use and a good idea. But then when they used the ampule opener, their physiology changed. They stood up straighter, their eyes lit up and they smiled. Some even tried to buy one on the spot. At first, I was taken aback seeing these highly educated, highly intelligent nurses subconsciously saying that they were more scared of cutting themselves with a glass ampule than with a used scalpel blade with a patient's potentially infectious blood on it. This made no sense at all. Eventually, I realised what I was witnessing. Ampule cuts are extremely common. They are experienced at least once by 1 in 3 nurses. So when a nurse cuts himself or herself, he or she can blame the ampule. They can show their injury to their friends and get some sympathy. The responsibility for the ampule cut can be easily relegated to the fault of the amputable, not themselves. But now imagine you're a scrub nurse in the operating theatre. If you cut yourself removing a used scalpel blade with your fingers because you were distracted, you blame yourself, not the scalpel. You will tell yourself you have failed to do your job properly. You are embarrassed and you try to keep the injury a secret. You don't report the injury. You don't look for safer alternatives to prevent the injury recurring. So what I was observing was the paradox of blameworthiness. We teach our staff to operate in a no-blame culture for patient safety, but we are happy to accept, even encourage our staff to operate in a blameworthy culture in relation to their own safety. Let's take a minute to think about this. Do you think it is possible for anyone to operate in two diametrically opposite mindsets at the same time? As a result of this paradoxical mindset, both staff and patients suffer more often than they should. Let me run through a short summary of how this concept has matured. In 1999, we thought staff safety would improve if we improved patient safety first. In 2008, a few colleagues and I set up staffandpatientsafety.org to start focusing on staff safety, both physical and psychological. In 2009, early Canadian research confirmed the link between staff safety and patient safety. In 2011, our BMJ article, previewed in an earlier slide, was published. In 2013, the Victorian government underwent an audit of public hospitals in regard to occupational safety. They found it severely lacking. This report highlighted the failings to healthcare workers and patients where staff safety was not prioritised. So there were some people starting to understand this link between staff safety and patient safety, and then 2020 happened. If there can be such a thing, the silver lining on this past horrific year has been the public spotlight on keeping health workers safe. There have been protests all over the world to ensure governments allocated resources for PPE, and the World Health Organization made their 2021 theme for World Patient Safety Day, Health Worker Safety, a priority for patient safety. A quotation from this 2020 article in The Lancet states it clearly. There now needs to be universal recognition that health worker safety is patient safety. One cannot exist without the other. We need to act now. We need to cement staff safety as a core KPI in every hospital. We need to establish policies and procedures and even legislation to ensure that actions to improve staff safety are sustained in the long term. They need to become part of the new accepted day-to-day norms. The current COVID pandemic has painted a very clear picture on how closely linked staff safety and patient safety are. Firstly, and perhaps most obviously, the role PPE plays. News stories continue to show hospitals lacking PPE. Without adequate PPE, nurses and clinical staff are more likely to be infected, and then more likely to infect a patient. Secondly, the number of healthcare workers available to treat patients has been impacted by COVID-19. Between workers having to take leave for treatment, isolation and quarantine when infected with or exposed to the virus, and the increase in violence against healthcare workers, the correct staffing ratios have been difficult for many countries to maintain. Low staffing levels and overworked staff has been established to have worse patient care. Low staffing levels and overworked staff has been established to lead to worse patient care. Finally, nurses and clinical staff are the ones fighting on the front line of this massive health crisis. And as such, they have experienced higher levels of distress and exhaustion on top of their higher rates of infection. I remember reading stories of nurses from Victoria spending all day caring for COVID patients, only to have to isolate themselves from their family at home to prevent infecting their vulnerable loved ones. It has been over a year now since this disease hit Australia's shores. and the long-term mental stress will continue for some time. For nurses and clinicians, psychological distress and exhaustion can lead to more mistakes being made and patient safety suffering. A mate of mine working in ED lived in the shed for a month while his wife, a rehab nurse, lived in the house. Each of these three specific examples have an obvious negative effect on patient safety. But COVID is not the only situation where staff safety is neglected. We need a culture to proactively promote staff safety as well as patient safety, not an ad hoc one-off reaction to an issue when it hits the media. We need to make clinical practice safer for both staff and patients. This may sound daunting at first, but in the next few slides, we will investigate how you can play a part in improving your own safety in the workplace, as well as the safety of your colleagues. Let's put a human face to patient safety. Mrs. SH was a young mother-to-be who lapsed into a coma after being given 100 milligrams of morphine instead of just 10 milligrams. Mrs. SH was rushed to ICU, but her baby died. Up until this medical error, it was an uncomplicated pregnancy. The nurse was stood down. This happened in January of this year in Perth. How do you feel about this story? Will the parents ever get over this loss? How will it affect their other children? Is blaming the nurse the real solution? How often does the nurse get blamed instead of conducting a proper root cause analysis? My initial reaction was to want to get into a time machine and go back and prevent the overdose, to save the baby's life, to stop the parents' lives being destroyed, and to stop the nurse or nurses suffering from the second victim syndrome. Unfortunately, we don't have a time machine. So my next thought was, what can we do now to prevent this happening to someone else in the future? Now ask yourself, are you aware of any other examples of patients being given the wrong dose of a medication? Have you ever done it yourself? If the system had acted on that earlier error, would Mrs. SH's baby still be alive? Acting now is the time machine for tomorrow. Let's put a human face to staff safety. Karen Daly was working a weekend shift at triage in the emergency department of a Boston hospital in Massachusetts back in 1998. By the end of her 12-hour shift, she was tired and could only think about going home. A nursing colleague was having trouble drawing blood from a patient, so Karen stepped in to help. During the process, she stuck herself with the needle. She was exhausted and all she wanted to do was go home. But her colleague, who now felt very guilty, insisted Karen report the incident and have the blood tests and follow-up. To cut a long story short, Karen seroconverted with both HIV and hepatitis C. This happened 6 months after the Sharps injury. The next 12 months were very traumatic. Drug side effects, mental anguish about her unknown future, and disruption to family life. The last month of treatment was the worst. She told me that the estimated costs of her drug treatment was well over $1 million. How would your life have changed if this happened to you? How would you tell your spouse? What would you say to your children? My initial reaction, after I got over the denial that it could actually happen to me, was to get into a time machine and go back and not stab myself with the used cannula. Unfortunately, we don't have a time machine, so my next thought was, what can we do now to prevent this happening to someone else? Ask yourself, are you aware of any other examples of staff having a Sharps injury? Shouldn't be too hard, as it's estimated that there are 18,000 reported ones in Australia annually. Have you ever stuck yourself? If we had acted on that earlier injury, would we have avoided our injury and potential infection with HIV and hepatitis C? Acting now is the time machine of tomorrow. And I again put my hand on my heart and state that improving staff safety and patient safety is the same set of principles. The underlying causes are the same. They are systems errors, not deliberate human mistakes. To address a problem, we have to first identify the problem. Please have a quick read of this list of occupational hazards made by Safe Work Australia, such as respiratory hazards, think COVID, back injuries, violence or Sharps injuries. Ask yourself, How many of these risks do you recognise from your workplace? How many of these risks have you just accepted as being part of the job? Now, to solve the identified problems and make clinical practice safer, we need action at 3 levels. At the national level, we must acknowledge the problem and establish the guidelines, regulations, and even legislation to address those problems. At the organisational level, we must fund the implementation of these strategies and measure both the change in practice and the results of this practice change. And last but not least, at the individual clinician level, we must both enact the solutions and give feedback on ways to improve the solutions. As with James Reason's Swiss cheese model used to explain the consequences of systems failures, all 3 levels have to be enacted at the same time to avoid preventable injury and error. I'm going to go through each of these individually in a bit more detail and look at ways that as an individual clinician, we can have an impact on each of these levels. The World Health Organization has recommended actions that should be undertaken at the national level by countries in order to set a framework for organizations to improve staff safety. These actions include establishing a blame-free and just working culture. This is a given. Implementing or aligning patient and occupational safety standards, including infection prevention. To take an extreme example where alignment is missing, the patient safety body would tell you to wash your hands to reduce post-op infections in patients. And then the staff safety body would immediately tell you to wash your hands again so that you don't die of COVID-19 or take it home and infect your spouse and children. Surely washing your hands once properly is the key here. They recommend incorporating staff and patient safety requirements in licensing and accreditation standards. I believe Australia needs sharp safety legislation like the USA and Europe. But in the meantime, why don't we start to comply with current workplace health and safety legislation that's used for the rest of the population? For starters, give junior nurses permission to speak up for their own safety. Developing national programs for occupational safety in healthcare. Other industries do it. Why can't we? The World Health Organization also included providing adequate resources to prevent injuries to healthcare workers. Providing the resources is only half the issue. We need to audit that the resources are being used and used properly. For example, auditing the number of safety devices purchased and auditing the amount of soap being purchased. The World Health Organization also recommended providing access to mental well-being support services. This is another example of what's good for staff being good for patients. I often suggested to my patients who were stressed with a new acute illness or the persistent symptoms of a chronic illness that they should use the mindfulness app that medical students and interns were using. I would say that if it is helping the young doctors, it should also help you. Please ask yourself, what can I do now? I have a few suggestions. Firstly, know what support is already available for you. For example, workplace health and safety legislation, specific advice on sharps management policies, such as that on the Queensland Health website, and Australian standards on blade removal, etc. Share this information with your colleagues and your managers. When the support isn't there, lobby through your professional bodies and unions to get the support you need. And take the opportunity to participate and provide your feedback at every opportunity. For example, on staff satisfaction surveys, bring up staff safety issues. The organisational level is where the most impactful actions lie. Hospitals and healthcare institutions are required by law in Australia to keep their staff safe. Yet, as we have seen, there are complex issues at play which can prevent this happening successfully. Some key strategies which all organisations should implement and maintain include the following. These recommendations have been taken from those provided by the CDC in the USA and the Victorian Auditor General's Office after their 2013 audit. Firstly, develop a safety culture, making responsibility roles clear. Maybe a safety share at all your regular meetings to start with. Ensure resources and safety devices are sufficient. For example, audit purchasing data in your department as a measure of safety device use. The third one was to establish and maintain an injury reporting system. I'd go further and suggest you set up regular meetings to review this data and then analyse the causes to plan prevention strategies. Provide comprehensive safety training and information to all healthcare workers and even hospital board members. The latter is important as top management has a big influence on culture, and we want a culture of safety in our hospital systems. Establishing a safety committee consisting of representatives from different disciplines, and I'd suggest you try and get onto those. Finally, preventing occupational hazards through control measures. Let's look in more detail at the hierarchy of controls. The hierarchy of controls dates back to 1950 when they were developed by the National Safety Council in America. They took an upside-down approach to the behaviour-based safety programs that ignored hazards and risks and instead focused on critical worker behaviours. The old way of dealing with staff safety relied heavily on elaborate mechanisms to check, inspect, observe, coach, reward and discipline workers. Does this ring a bell? Over the last 70 years, the hierarchy of controls has been standardised across most industries to reduce risk in a systems-wide manner. Healthcare is finally reviewing and adopting this proven approach. Using the hierarchy of controls to manage occupational risk is mandated in regulations across Australia and throughout most of the world. They describe 5 levels: elimination, substitution, engineering controls, administrative controls, and PPE. I'm going to highlight these different levels using the example of sharps injuries, as it is a significant and often overlooked safety hazard, to illustrate how organisations can optimise staff safety using these principles. Firstly, elimination is obviously the best way of reducing injuries when it is a possibility. Examples would include eliminating unnecessary injections, for example, administering antibiotics orally instead of intravenously or intramuscularly, or by using glue rather than sutures to close appropriate wounds. From a practical point of view, you could work with your ID colleagues to write a policy or guideline to determine when emergency antibiotics can be safely changed to oral. Similar to elimination, substitution is an excellent way of reducing injuries. Examples would include introducing needle-free intravenous access systems and using blunt-tip suture needles when closing muscle and fascia. From a practical point of view, you can look at ways of strengthening good practice changes. For example, I understand using needleless IV systems is now the norm. If this is the case, you could review how this change was implemented. For example, budget, work practices, guidelines, updates, etc. These tips can be used in the future. It might include flagging the unsafe devices in the purchasing computer system and requiring that they need special permission from a designated person before they can be bought. However, in many cases, the elimination or substitution of a sharp is not physically possible. For example, the need for scalpels to make the incision to create access for the surgeon. In such scenarios, engineering controls allow for the best ways to reduce injuries. Engineering controls are devices specifically designed with a safety feature to protect the user from injury. You may come across examples of staff using artery forceps to remove blades. But are artery forceps designed to do this? No. Whereas a scalpel blade remover is specifically designed to safely remove blades, and as such, only the latter is an example of an engineering control. Other examples include retractable syringes and the now ubiquitous sharp spins. From a practical point of view, if you or a colleague are still using fingers or forceps to remove used scalpel blades, even if only occasionally, it's time to stop this practice. Using workplace health and safety legislation will assist you in making a change in department policy, and a referral to the Australian standard will ensure the best change possible is made. It needs to be noted that all safety devices are not equal. So when selecting engineering controls, it is important to distinguish between passive and active safety devices. One particular study showed that passive or automatic devices were involved in 70 times fewer injuries than the active or manual devices. Consistent with these latest research findings, the recently updated Australian standard AS 3825/2020 recommends using passive or automatic devices, which they define as a device in which removal is automatically performed with no extra action being required by the user, in preference to active or manual safety devices in which removal is manually performed by the user. Administrative controls are essentially there to ensure that staff actually enact the hierarchy of control solutions agreed upon. They include writing policies, including an exposure control plan, and ensuring staff are adequately trained in safe work practices and the use of the engineering controls. In practical terms, administrative controls can fall short of their potential if they don't have effective metrics included and regularly implemented. A simple example is measuring and monitoring hepatitis B vaccination and training on new safety devices. Encouraging the reporting of sharps injuries is also important, and this will be more successful when such reporting of staff injuries can be done in a no-blame culture. From a practical point of view, provision of online multimodal educational tools for training on the use of engineering controls, especially simulation apps, should be used wherever possible. This needs to be part of all orientation programs for new staff and then annual review for all relevant staff. Personal protective equipment is probably the most universally identified way of keeping staff safe. However, it sits at the bottom of the upside-down pyramid for a reason. It is the least effective way of protecting staff from injuries. PPE is almost the option of last resort. The first four levels need to be given greater significance and need to be implemented in conjunction with PPE, not replaced by PPE, and disposable gowns and N95 face masks. From a practical point of view, you need to get trained on using the PPE, the don and doff sequences. Then you actually have to use the PPE in the correct sequence. If you are in a management position, monitor purchasing data to detect if and when the use of PPE is dropping off and address it. Now, if these principles had been implemented in healthcare when they were being implemented in other industries, Karen Daly's story may not have unfolded. You may not have suffered your sharps injuries. I would like to summarise my beliefs to date and go one step further. Staff safety is important in its own right. Positive staff safety has a positive effect on patient safety. Principles to achieve improvements in staff safety can be duplicated to achieve improvements in patient safety and vice versa. For example, let's look at how the principles of the hierarchy of controls can also be used to improve patient safety. I will use the example of falls prevention in the elderly. Firstly, elimination. Removing trip and slip hazards, for example, a loose rug in the home of an elderly person. Next, substitution. Replacing old floor tiles with non-slip tiles, especially in wet areas such as bathrooms and laundries. Engineering controls. This could include the installation of grab rails and stair lifts. Administrative controls. Writing a falls prevention plan with your at-risk patients and their carers. Translating it if necessary. Finally, the PPE. Wearing hip protectors to reduce hip fractures when the patient falls. Again, this is not as effective as preventing the fall in the first place. Let's have one congruent mindset and problem-solving matrix to achieve optimum safety in healthcare. Coming back to our levels of safety, the last one is how you, as an individual clinician, can act now towards our common goal. For example, reporting injuries and near misses. Set the example for your colleagues. We can do better than just a 30% reporting rate. Maintaining an open line of communication with team members. Talk about safety shares at department meetings. Assessing peers and your own professional work habits and behaviours for safety risks. Tell them it's okay to be safe first. Utilising evidence-based practices. For example, using a passive or automatic safety engineered device. Participating in shared governance or safety committees. You just need to get on the committee. Speaking up when safety risks are occurring. I suggest this includes sharing the regulations and standards with your colleagues to help overcome the inertia and get the required action instigated. Helping when CAPA investigations are required after workplace injury or adverse events. This is similar to the M&M meetings for patients. Last but not least, completing hospital safety and quality survey and staff satisfaction surveys. I repeat, don't miss any opportunity to promote staff safety. Even though these actions may look insignificant, by taking action at a local level, you contribute to building a culture that prioritises staff safety. Remember the first thought experiment. Hopefully you will now agree that an injured staff member, such as yourself, immediately becomes a patient after an injury. Look at the list again and ask yourself, when are we going to stop accepting these workplace hazards as just being part of the job? Hopefully what we have gone through in this presentation will give you ideas on what you can do. In summary, unless you own or have access to a time machine, we need to act now to prevent injuries. We need to take advantage of the current situation while COVID is shining a spotlight on staff safety. Despite all my advocacy work to promote staff safety, I was often guilty of lapsing into risky behaviour when I was solely focused on patient safety. My personal strategy, which I'd like to share with you, to negate these long-established reflex reactions was to actively stop myself from diminishing the importance of my own safety by constantly reminding myself that staff safety is also about my friends and colleagues and our families. It has to be taken at least as seriously as patient safety. Staff safety is vital for keeping patients safe. Staff and patient safety needs to be supported at a national, organisational and individual level to be successful. Specific hazards can be controlled through national standards being set. Control measures like safety engineered devices being implemented in organisations and individual clinicians participating in these safety programs. My challenge for you going forward is to think about what you can do in your facility to promote staff safety and patient safety. Please don't hesitate to contact me if you have any questions or feedback about this presentation. Myself and the ClickSmart team are always happy to support you as you advocate for staff safety and patient safety. ClickSmart is a Brisbane-based medical device company that focuses on developing staff safety products. However, our mission is bigger than just supplying safety devices. It is to help healthcare facilities to be a safe place for staff and patients, a great place for you to work.